Welcome, it's Monday the 18th of May. Now this is much better when it's just you and me having a chat. I've just done one of these TV interviews and you feel so pressured for time. You actually don't really enjoy it, but when it's just you and me talking, that's great. Now, developments from the United States this morning and the United Kingdom. Great cause for concern in Russia, Brazil, Chile. Some very alarming material coming out of those countries. But let's start off, first of all, with Singapore. Just briefly now, Singapore is a bit of a mystery to me. It's a very sophisticated country. It's got, good governance. And they're saying that there's been 28,000 cases and 22 deaths. And this doesn't quite add up. Now, let's hope they're right and that the death rate actually is 0.07%. But in the rest of the world, it's like 10 times that. So the Singaporean data at the moment is not really making too much sense. So more to come on that, I think. But interesting that the Singaporeans are now using a non-mandatory contact tracing app. Now, Singapore is a very ordered society. And I must say I'm somewhat surprised that it's non-mandatory. I would have thought that the government of Singapore may well have mandated this, but they haven't, which is interesting. And of course, this is going to work out where you've been and who you've come into contact with and warn you appropriately so that testing, tracing and quarantine, isolation can be precisely targeted. In terms of controlling the pandemic, it's a good way to go. It's similar to the app, I think, that's been used on the Isle of Wight in my country as an experimental app that has been fairly well received by the population so far, I think it has to be said. More to come on these apps, that's for sure. Now, the United States, 1.5 million cases, 90,000 deaths, I'm afraid. That would give a case fatality rate of 6%. It's nowhere near that high for reasons we'll see shortly. Warmer weather in the United States, people going to the beach. Very limited mask wearing. Disappointing to see some political leaders not wearing masks. Mask wearing really needs to be mandated all over the United States. Or everyone needs to do it and they're simply not. It's not hard to wear a mask in a public place. It's not a big ask really. It's a pity it's not done there and in my country also. Videos on the news today. How representative they are, I don't know. Packed bars in Ohio over the weekend. People drinking in bars, far too close together. Chicago, some churches reopening. North California, an individual tested positive after attending a church with 200 people. It's too early, people. It's just too early. Too early to be drinking in bars, too early to be going to churches. Watch church online. More people are watching church online than ever attended anyway. Too early for these social gatherings, I'm afraid. And Memorial Day next weekend, and I believe that's a bit of a holiday in the States as well, so that's another cause for concern. Because there's still a lot of virus around in the United States, as we're about to see. Operation Warp Speed for the vaccine, hoping for a vaccine by January 2021. That would be the very earliest. If it comes by 2021, I would be very pleased with that. But huge steps are being taken in the United States. They have massive technological ability. I wouldn't put it past scientists and developers in the United States to have a vaccine by 2021. Let's hope so. January would be great. Now, this is interesting, a case I've been looking at in Boston. Now, Boston officially has got just over 11,000 diagnosed confirmed cases, 551 confirmed deaths as of a day or two ago. And Mayor Marty Walsh, in combination with the health authorities, instigated a study to look at the amount of people who have antibodies. Now, what they did was they tested 750 people from different neighbourhoods, sampled asymptomatic residents in 4 neighbourhoods, and about 10% tested positive. But I believe he also tested quite a few municipal employees, which is a pity because that means the sample wasn't very well randomised. But it's good that they chose 4 neighbourhoods because that gives you more randomisation. Now, 10% were found to be positive. So 750 people tested, so presumably 75 or so, 74 tested positive for the antibody to the SARS coronavirus 2. And of course, the antibodies are the immune proteins that the body makes in response to exposure to the virus, which is the antigen. And this is remarkably useful information because if we know who's got antibodies, then that means we can work out, for example, an accurate infection fatality rate. So if the official figures show that there's 11,000 infected, then the percentage of deaths would be 551 deaths over 11,395 times 100. I haven't worked that out, but it's quite a big number. It's probably about 7%. But I did work this one out for if it turns out to be 10% of the population of Boston, which is 78,000 people roughly, then that would mean that the sum is 551 over 78,000. And that equals, I believe, about 0.7%. Yeah, 0.7% I worked that out as. And that sort of infection fatality rate is what we've been seeing in other parts of the world. So, for example, we looked at a study in Spain a couple of days ago, and it worked out that about 5% of the population of Spain had been infected, greatly reducing the infection fatality rate down to about can't remember quite what it was, but it was in this kind of area. We looked at a similar study in Geneva, and that was 9.7% infected, almost exactly the same as Boston, with an infection fatality rate of 0.5%. Heisenberg in Germany, 14% of the population were showing antibodies, 0.4% of those died. New York, it was 21% had antibodies and 1.1% of those died. So this is roughly what we're looking at and is fairly consistent with other areas. A infection fatality rate of about 0.7%. And it's also remarkably useful to know if people have the antibodies, because you can work out this infection fatality rate. But also we believe that people with the antibodies are probably going to be immune, so they can return to normal duties. And also people with these antibodies could be blood donors. Give their blood. The blood transfusion people will separate the cells and the plasma, and then they will give the plasma containing these protective antibodies to people that are acutely ill. And there's some evidence accumulating that that is an effective treatment. So well worth knowing this. But what's it telling us overall in the round? It's telling us that about 10% of the population of Boston have been exposed to this virus, therefore have some degree of immunity. Of course, that's telling us that 90% have not been exposed to it. So 90% of the population are still vulnerable. So if the virus is around in the communities, 90% of people are still vulnerable. We lift the restrictions, we're going to get more cases. This is guaranteed unless we replace it with very accurate testing, tracing and isolating. And the study in Boston also showed that 1 in 40 people could still be antigen positive. Now remember, the antigen is the virus. So this was an antibody study, but they thought that 1 in 40 people could still have the virus. And the reason for this is the immunoglobulin type M's developed first and the immunoglobulin G's developed later. So these people would have the immunoglobulin type M's, indicating that they've been infected recently, so could still have the virus. It's only later you develop the immunoglobulin type G's. These are just different immune proteins, don't worry too much about the detail. So the fact that only 10% of the population are infected means we're still at an early stage of this pandemic. That's the takeaway message here. We're still at an early stage. There's a long way to go. 90% of people not yet infected. And we looked at the havoc that the virus has brought in Spain for only 5% of people being infected. So it was 5% in Spain, it's 10% in Boston. But we need at least 60% to have herd immunity, preferably 70%. And only then will the virus stop spreading when we get to these levels. So we are nowhere near that yet. It means there's a long way still to go, I'm afraid. Now, this is interesting. Monoclonal antibody therapy is being proposed. And this is a San Diego-based firm. I probably shouldn't advertise the name of the firm. And they're producing a monoclonal antibody. Now, a monoclonal antibody, mono means the same. So these antibodies are all the same. But they are antibodies that will combat the COVID-19 virus. So they're antibodies that will combat this virus. Now, the thing about antibodies is they are very complex proteins. And you can't just make them like you can aspirin or vitamin D, or it's not a simple molecule. So you have to have a tissue culture, and tissues and actual living cells have to produce these antibodies for you. So it's quite complicated. But this company is saying that they've developed a antibody which completely neutralizes the virus in vitro. And this is possible. This is possible. They said it plans to request priority evaluation and accelerated review. Their monoclonal antibody shows exceptional therapeutic potential and could potentially save lives. All that's true. It's not the first one. Israel's Biological Institute has also been working on a monoclonal antibody. So this is a possible line of treatment. It's a biological line of treatment where we get cells in culture to make the antibodies for us, then we inject those into people. So it's the very same principle as this plasma therapy. So in plasma therapy, I get the infection, the antigen, I make the antibodies go into my plasma. I then give you some of my plasma, therefore I'm giving you some of my antibodies that can fight the infection in you if you are acutely ill. And it would be the same if we injected monoclonal antibodies. It's exactly the same principle. But we must have a monoclonal antibody that destroys the virus. They claim to have that. It must be specific to coronavirus too. They claim to have that. And it must be monoclonal, so it doesn't have side effects and what we call cross-reactivity. And traditionally, monoclonal antibodies have been very expensive and hard to produce in bulk. So although in theory this is a completely curative measure, and in theory it would work perfectly, in practice it's going to be very hard to scale that up. But the principle is that this monoclonal antibody therapy would be effective if it works, so let's hope that it works. So interesting therapeutic possibility there, but we're not quite there yet as far as I know. And when we are, I do fear it will be expensive. Now, this is interesting. The UK, 250,000 cases, 35,000 deaths. And the government's talking about reopening schools next month. More of that in a minute. But my government's just added loss of smell and taste to the new guidelines. So they did say fever and cough. Now they say if you lose smell or taste, or you have a cough, or you have a fever, then you should self-isolate for 14 days. We actually reported this back in February, actually. But they're now saying it's significant enough to merit isolation for 14 days, that you may have the infection. Now, this thing about schools going back. Now, the World Health Organization are saying schools are not a major form of transmission. And this is this leading scientist, doctor from the World Health Organization saying this. She says there have not been big outbreaks in schools and the early results of studies are very reassuring. The risks to children are extremely low with this infection, and there have not been many cases described in children transmitting it to others, particularly within the school settings. Now, this is interesting actually, because we looked at this study in Spain a couple of days ago, looking at antibodies, and they did find that children, there was a smaller percentage of children infected with antibodies than adults. Did this mean that children weren't infected in the first place, or did it mean they weren't making the antibodies? We don't know. But it was somewhat less. Now, if that's the case, I must say I'm going to be surprised, because if there's a virus that affects adults but doesn't infect children, that would be surprising. But it may be the case. If that's what the data is showing, that's fine. But that's certainly what this scientist from the World Health Organization is intimating here. It appears that children are less capable of spreading it even if they get the infection, and certainly are at very low risk of getting ill from the disease. So that is true. And yet, the schools opened up again in France just recently, just last week. There was about 30% of the school children in France, the younger school children, went back. This is primary schools we're talking about in the UK, not secondary schools. But there's been 70 new cases linked to schools in France, and 7 schools in northern France have just closed down today. So the theory from the World Health Organization sounds good. Let's hope it's true. A little bit of practice from France indicates that there may be more problems than we anticipated. Now, vaccines in the UK, the Oxford group, they're optimistic that they can have 30 million doses ready by September 2020. Now, if this turns out to be the case, this is just going to be utterly mind-blowing. Now, if it wasn't a group from Oxford, and a sophisticated group working with AstraZeneca, you would just dismiss this as science fiction. September's only, May, June, July, August. They're talking 4 months away. The reason I am somewhat optimistic about this group had been working on other coronaviruses for years. So they had a head start when it comes to coronaviruses. So it could be they are that advanced. Let's hope so. So 30 million doses for the UK, then 100 million doses by September is what they are saying is possible. Now, we're not there yet. There's other questions still to answer. But it would be surprising if this group were being so optimistic if it was based on nothing. I suspect there are grounds for optimism there. Time will tell, of course. 100 million doses by September would be very nice. And they've also committed to producing it at low cost for developing countries, which of course is essential because this is a pandemic. We're all in it together. So then we'll have contact tracing, testing, tracing, isolating and vaccinate as well. That's the bit we're waiting for. So contact tracing, testing, tracing, isolating, vaccinating. All kind of rhymes. It's all the order we need. We're waiting for the vaccination. Until then, we have to do much more of this, as I've said many times. Italy, great reopening now in Italy. Let's see what happens there. There are going to be more cases. Let's hope they remain manageable, though. Thailand, external flights still cancelled. Curfew's getting shortened, so you can stay out till 11 o'clock now in Thailand. Malls are reopening. Everyone wears masks and everyone socially distances. So it looks like public behaviour in Thailand in terms of mask wearing, social distancing, has basically truncated the outbreak in Thailand, combined with testing, tracing, isolating, tracking cases. Low-tech approach, but it seems to be working, which is remarkably encouraging. Remarkably encouraging. Brazil is not remarkably encouraging. In fact, it's downright alarming. Cases are higher than this. Rio de Janeiro hospitals are at capacity. The mayor of Sao Paulo has said his hospitals are near collapse. And a second health minister has resigned. Political problems that we probably know about from the top in Brazil. Now, if the hospitals collapse, that means maybe 10% of people who are quite ill will be waiting in streets outside the hospital trying to get in. They won't be getting the medical treatment that they need. And that means that many of the people that the hospitals could have saved will not be saved, but will die. So the case fatality rate will go up. Now, the overall infection fatality rate globally, we're looking at about this 0.7, aren't we? From the data we've looked at, that would be the situation in Boston, for example. 0.7% of the population, 0.7% of people who catch this virus die from it. But if 10% of people are getting quite ill, and say 5% of people are critically ill, then I don't really see why that doesn't increase the case fatality rate to around about that figure. And that, of course, is terrifying. Because the San Paulo hospital is near collapse. Chile, also greatly increasing cases. The lines are up. Santiago is closed down. Police permits needed to go outside. Violators heavily fined. ITUs in Santiago are full. In Chile, and I believe the hospitals are struggling significantly as well. Does that mean that within the next few days, people that need treatment in Chile will not have access to treatment? I'm afraid that's exactly what it means. Does that mean more of these people will die? I'm afraid I think it does. Russia, likewise, greatly increasing. The health services in Russia have recently been optimised. And optimisation is a euphemism for shutting a lot of it down to save money. So again, I suspect the hospitals in Russia are greatly struggling now. Now, China, testing all 11 million people in Wuhan, phenomenal effort on testing. But in Jilin, in the city in the northeast, which borders Russia, I believe, 144 cases, so the city is shut down. So disconcerting to see this cropping up again in China, but probably imported cases from Russia, but there has been some community spread here as well. And there's several clusters apparently in Jilin city of more than 20 cases. 500 medical staff have been sent to Jilin. Now this is somewhat reassuring because I remember in Wuhan, when things were bad in Wuhan, the Chinese government sent 50,000 medical staff to Wuhan. So 500 medical staff sent to Jilin is still a relatively small amount. So let's hope they have that controlled. I strongly suspect they will. So many lessons have now been learned. Domestic flights in China back to 60% capacity. World Health Organization not yet allowed access to China to investigate things like the cause of this pandemic. Now, on this channel, we're no great fans of the World Health Organization, but the teams they can put together are the best in the world. So they need to be allowed in to investigate what's gone on, but China has said it's premature. Let's hope that means they will allow these world-class investigators in shortly. Egypt, strict curfew for Eid. Cases increasing in Egypt. Again, many people live in very difficult housing situations in Egypt. India, increasing cases, increasing deaths. Now, the testing in India is very low, so it's way, way higher than this. 45 million migrant workers are getting towards home now, carrying the infection from the city into all parts of the country. Lockdowns extended to the end of the month. Country and cities are divided into green, orange and red zones. And the lockdown is titrated by the colour of the zone. So green zones relatively free, red zones highly locked down, orange zones somewhere in between. And this is the way that the whole world is going to need to go. Particular parts of the country, particular cities are going to need to be locked down, whereas others can be opened up. And that's going to need to be done on a dynamic basis, as the situation dictates. Still no international flights into India. Now, Australia, just to take New South Wales as an example, churches are open for 10 people, churches, mosques, synagogues, 10 people allowed. Many people are still not going back to church, so a lot more restraint in Australia than there is in other countries that we've already mentioned. Many churches just continuing live streaming. 10 people allowed in coffee shops. Now, Australia, coffee is a serious business in Australia. Very, very serious business. So New South Wales is allowing that. And it's, I'm not saying these things are unreasonable. I don't think they are, because the Australians have done very well. And in Australia, things are going by the state. They have individual state regulations as well, somewhat similar to the United States. Now the sun's come out, so I probably won't be able to see anything, but I think you can see things here. Let me see if I can see what's going on. So this gentleman is from Nigeria, and I'm not going to try and pronounce your name. Sorry. Oh, there we are. That's better. This is Adam from Manchester in the UK, taking full precautions, I'm pleased to see. This is Arena in Pennsylvania. So thank you for watching in Pennsylvania. Glad to see you taking the vitamin D. This is Alan, who's in Salt Lake City. Now that is in Utah, is it not? I think it is, yes, Salt Lake. So good to know you're watching in Salt Lake, Alan, thank you. This is Alicia, and that looks like Alicia's in Salt Lake as well. There you go. Very convenient that you put that on there, otherwise I would have forgotten. Great to know we have those 2 viewers in Salt Lake. This is Andrew, who's in Michigan, who's obviously a serious outdoor type. He's watching videos on a boat by the looks of it, so excellent. Thank you, Andrew. Is that Lake Michigan? It probably is Lake Michigan, isn't it? There is a Lake Michigan, isn't there? Sorry, my American geography is appalling. This is Angel in Chicago. Good to know you're watching in Chicago, Angel. Thank you. This is Angela in New Zealand. So good to know Angela's watching in New Zealand. A country that's done particularly well, it has to be said. This is Donna, and she is in, at a rough guess, Port Moody, British Columbia, watching across there in Canada. And she says, I take 2,000 international units of vitamin 3 a day, which is of course what I take as well. What does she say underneath there? I have for a long time, as per my doctor. He says most Canadians are D3 deficient. Isn't that interesting? So, Donna, that is a remarkably useful slide. I really appreciate that. Excellent. Thank you for that information. And a very clever way to communicate it, I must say, holding the poster up. What a good idea. Thank you, Donna. Appreciate it. This is Krista in Arizona, down south. Glad to see you watching in Arizona. And that is us for today. Thank you for watching.